Hello, everybody, and welcome to this 36th episode of the RSM's COVID-19 series. This series is for health professionals, by health professionals, and designed to give healthcare workers on the front lines regular and easy to access updates from healthcare leaders on COVID-19. You will see there's a Q&A feature that the audience can use to ask questions during this session. Today, we will be focusing on to some extent on non-COVID activity in terms of maintaining and restoring specialised services during the pandemic. In other words, how did we keep the vital cardiac and cancer and intensive care services going in the peak of the pandemic? How are we going to restore those services for the benefit of patients over the next few months? And what are the gaps and problems and barriers towards doing that? And we're really focusing principally at the minute on London, on the London response. And we've got some really very distinguished and great speakers. We start with Professor Ewan Gray, who was the National Cardiovascular Clinical Director until recently, and is now the Cardiac Network Clinical Lead for London. We have Professor Julia Wendon, who's the Clinical Director for Critical Care in London. We have Mr. Stephen Edmondson, Chief Surgeon at Barts Health, who really led the cardiac surgery programme for London during the pandemic. And Professor Thomas Powles, who's the director of the Barts Cancer Centre. So I'm delighted that you've all agreed to join us. And I'm going to start off by asking Ewan just to describe a little bit about how London Regional NHS is organised and how it responded in those early days to the pandemic. What were the sort of forums where decisions took place?
Thanks very much, Charles. Obviously, my comments are going to be largely directed towards cardiac services, but I think that has a fair amount of overlap with other services in London. We have a clinical network jointly funded by CCGs and NHSE London region. This network is strategic and reports to the Cardiac and Stroke Transformation Board in NHS England London region. And on it, there is strong STP, ICS and CCG representation. In addition, we have two operational delivery networks, and as their name implies, these are focused on operational rather less than strategic issues. The two ODNs, the one in South London has existed for a few years, and the one in North London has been in place for a few months and largely generated by the response to COVID. The clinical network and the ODNs work closely together. And in addition, we have weekly calls of providers for cardiology and for cardiac surgery. Steve Edmondson chairs the cardiac surgery weekly calls. And with this collaboration between the clinical network, the ODNs and provider units, we discussed and generated proposals for changes in clinical care pathways during the COVID pandemic, produced documents related to these proposals and submitted them to the Pan-London Clinical Advisory Group. Examples were things like revised pathways for the management of heart attack and major arrhythmias, out of hospital cardiac arrest. And in addition, more recently, a document covering a framework arrangement for delivering elective care in the restoration and recovery phase. And the last thing I'd say, Charles, is that most of cardiac services delivered in hospitals are specialised commissioned as opposed to CCG commissioned. And so we have a very close working relationship with NHS England's specialised commissioning team in London. So I hope that gives some outline.
What struck me during the early days of the pandemic, when you're leading that response for the cardiology network, was that these decisions were clinically led. They were coming from the clinicians. And can you just expand a bit about how those vital decisions got implemented?
Yes, I think it's one of the it's one of the few positive things that has come out of COVID, in my opinion, which is that the degree of collaboration between clinicians and between institutions, between hospitals, has been superb. I think it has generated a much more positive approach towards delivering cardiac services in London. And I was going to say later, hopefully this will be maintained after the COVID crisis is finally over. The proposals that have gone to the clinical advisory group have been consensus proposals from the clinicians, both in provider units and also those involved with commissioning or from a strategic objective in the clinical network. So the clinical advisory group has had the benefit of a very clear direction, very clear steer as to what the clinicians feel is the most appropriate way to manage clinical care pathways.
Great, thanks. So I'm going to move on to Jules, because you really are fulfilling a sort of analogous role for intensive care across the capital. And can you just give us a flavour of those really pretty scary days in March when the modelling seemed to go up and up and up each day, and how you responded to that?
Indeed, and I guess things started off quite quietly. We were all working within our ODNs and within our hospitals, beginning to plan for COVID as we saw it developing across Europe. And then the rate of patient growth and identified cases was clearly escalating, with increasing doubling time, such that we got to a point where we were initially predicting potentially 4,000 beds needed for ventilation, and then 7,000 beds, which are probably numbers that none of us could really comprehend. London really pulled together through the ICSs and through the ODN structures. And through that, we developed two streams of work. One stream focusing particularly on the XL Nightingale to provide a large ventilatory and critical care capacity as a resilience forum for London, and the ICSs and ODNs working very strategically and tactically together to identify critical care beds within what one might call core trust facilities. And within that, over a weekend and then iterated, we managed to identify some 2,500 beds. The staffing developed over the considerable time in that period. And there were points in that where we were procuring and sourcing ventilatory equipment, consumables for those beds. And particularly, I think I would highlight the evolution of the transfer teams. So we moved effectively from what had been 3 ODNs across London to 5 ODNs, clinically led, operationally supported, and it became clear that that was the functional grouping we needed for this crisis. We needed to move patients around those systems and across London really quite agilely in order to ensure that hospitals weren't overwhelmed, and the system set up transfer teams, 2 or 3 per ICS, which facilitated those transfer of patients. During that period, we had daily and often more calls with the ODNs and with the hospitals. And through that, we actually had both clinical leadership and real-time learning as we began to understand what the COVID disease process was.
And it's probably, just to follow up on a bit of the outcomes of critical care for COVID in the capital, it's probably a bit of early days, isn't it? Because there was a lag in terms of ICNARC, which is the audit of outcomes within ITU. But do we know how we did? Do we know how we compared with New York or Berlin?
So it's actually fascinating. It's when you get into this that you realize we are way ahead as a country in how we collect critical care data, and it is almost impossible to provide those benchmarks easily. However, having said that, ICNARC have been amazing. They've been producing weekly reports on a national basis. We are now getting through the individual trust data, and we're beginning to look at that. There's a fair amount of variance which probably relates to case mix. And what's come out of this already is that the case mix and mortality predictors that we use for standard critical care are not applicable to COVID. So that's layering a complexity into it. Though we know that in terms of duration of time, our outcomes improved over time. So as we learned how to deal with the inflammatory syndromes, the renal failure, the prothrombotic state, and the cardiovascular, as well as the ventilatory and systems effect, our outcomes for patients seem to have sequentially improved over time.
And could you just say a little bit about Ecmo, for those of you who aren't used to all these acronyms, and please can we all try and avoid the acronyms as much as possible. So Ecmo is basically temporary heart-lung machine. I remember at the start of the pandemic, there was a feeling that it might not be very useful at all in COVID, but actually some of the results have been pretty good. Could you just say a brief word about that?
Indeed. I mean, again, and this is, I think, all part of the learning. So we also learned that NIV seems to be more useful than we thought. And then at the other end of the spectrum,
NIV, non-invasive ventilation.
Non-invasive ventilation. My apologies, you say it and I do it immediately. Acronym. So Ecmo at the other end of the spectrum, when standard ventilation is no longer adequate, was shown to be really efficacious. And again, London came together. We had our 2 standard Ecmo centres at Royal Brompton and at GSTT. And in order to further provide capacity, Barts also were commissioned under those circumstances to provide Ecmo. And the outcomes from Ecmo, at least as they're being reported at the present time, have been really excellent. So real understanding of how we can support people optimally across that severity pathway.
So I think that's a very powerful message that within this brief period of time, we have found new ways and deployed old ways to get real improvements in outcome in these very, very sick patients that end up on intensive care. So I'm going to turn to Steve now. Obviously, again, back in March, we were faced with trying to maintain at least emergency cardiac surgery in a situation where we anticipated that London would have no available ITU beds because they would be full of patients with COVID. So can you say a little bit about how you approach maintaining that emergency service?
Yeah, thanks, Charles. So just to emphasise Huron's point, this really was a collaborative effort from all 7 cardiac surgical centres in London. We came together and we identified the 2 centres who would have a chance of having ring-fenced ITU capacity that could support cardiac surgery. So those 2 centres, geographically convenient, were one in the west, Airfield, and one in the east, Barts, and they became the 2 delivery centres for the programme. The programme was termed Pan-London Emergency Cardiac Surgery, which we abbreviated to PLEX. We rapidly agreed a prioritisation framework to identify urgent and emergency patients. You may say that's self-evident, but it was important to exclude the patients who we were not going to consider for cardiac surgery during this time. The logistics were such that we set it up so that patients would be referred from their normal DGH hospital setting to their cardiac centres where the triage would take place to keep the involvement of the cardiac centres and ownership of the patients for aftercare. And then following triage, the patient was then referred to the 2 delivery centres. In fact, in time, patients became to be increasingly referred directly to the 2 delivery centres. So we had inter-hospital transfers and we had emergencies. And what we did was have an overarching policy to try and avoid, if at all possible, operating on COVID positive patients, because we knew by then, both from our own experience and from reports that were beginning to emerge from Europe and Asia, that patients did extremely badly if they caught COVID post-cardiac surgery, looking at a 10 times the normal mortality. You have to bear in mind that we were doing this at a time when our swabbing techniques were throat swabs with a 24-hour turnaround time and up to a 30% false negative rate. So that did add in an additional challenge. What we did was devise very strict protocols to avoid operating on COVID positive patients. So when a patient was at another hospital, that was quite easy because we could get all the tests done at the other hospital. And these would comprise blood tests and an initial swab. And if they were all negative, then transfer to Barts or Airfield, where there would be a further swab and a CT scan, which we felt would also help exclude patients with COVID. once patients had got through all of that, then they were taken forward for surgery. Of course, with emergencies, there was no time to do that, and therefore those patients were treated on the basis that we did not know their COVID status, and therefore were operated on with full PPE. But we did something in both these groups of patients to try and help the certainty with which we could identify the patients as COVID negative or positive. It's probably important just to dwell on that for a moment. I'm talking about bronchoalveolar lavage swabs, because whereas the throat swabs would have a 30% false negative, the specificity of bronchoalveolar lavage, BAL swabs, is around 98%. And indeed, we had patients who were throat swab negative and became BAL positive. So we would isolate the patients post-op till the BAL was through.
Just explain how you do a bronchiolar lavage for people.
So this was done, so of course, in order to do this, you have to be anesthetizing the patient, and just before intubation, there's a bronchial alveolar washout, and that sample is captured, and that becomes the specimen for analysis. So clearly it has to be patients that have a general anesthetic, otherwise it's not possible. But it was very useful to enable us to identify patients who had been throat swab negative, but were indeed positive. So that was the basis on which we operated on very largely COVID negative patients. And in fact, we had really three phases. The initial phase, when we were very anxious about admitting and operating on COVID positive patients and very wary of the likely poor outcomes. And so in that first phase, quite a number of patients, their surgery was deferred or they were referred on for percutaneous intervention. As we became more secure around our protocols, the activity increased, and we had a middle phase where we did the bulk of the patients. And then as we get toward June, middle of June, the 7 centres around London were beginning to recover some capacity, and we agreed then that we would move to urgent at-home patients because, of course, these patients had moved forward in the natural history of their disease, and there were quite a number of patients who had escalated, if you will, from being stable to being urgent, and we then moved on to operating on some of those patients. So in total, we decided Plex would finish effectively on July the 7th, which was when emergency activity was restored across London. And between March the 23rd and July the 7th, we operated on over 600 patients without a single patient having a COVID-related complication. And one possible example of change from COVID negative to positive, though that patient had no clinical issues, and we still believe it may have actually been a false positive. So those were the outcomes. Important to say that the whole point of this was to achieve mortality that was down to the patient's cardiac disease and not related to COVID. So our outcomes, which was a 0.9% mortality for that third phase of patients, which were effectively urgent elective, was in keeping with pre-COVID mortality, and a mortality of 3.7% for the very urgent patients, again, in keeping with pre-COVID mortality.
Thanks, Steve. It's, again, incredibly impressive response, both in terms of the collaboration between the centres and the fact that virtually no one contracted COVID, and you're achieving the same outcomes as usual. So amazing. So I'm going to turn to Tom. I know, again, if we can go back to March, there was a great deal of anxiety about the very substantial risks for cancer patients from COVID, those receiving chemotherapy. And there was a real desire to sort of to shield cancer patients and keep them out of hospital in some ways. Can you just talk about how you've managed cancer treatment throughout the pandemic?
Thanks, Charles. So, so there are 165,000 cancer deaths in the UK every year, and each cancer centre, big cancer centre, probably would have 3,000 patients who are having treatment. One of the issues with cancer treatments is they take months, they're given in cycles, and they're ongoing. And so the challenge that one faces is around, you can stop treatment on patients, but that will have quite profound consequences. And although we hear a lot about the number of new patients dropping, actually when you look at the turnover of patients, it still remained above 90% throughout this period. So each cancer centre was given a challenging decision to make about how many patients they would continue, how many patients they would stop therapy on, and how they would deal with new patients. And as I said before, the real issue is around how do you continue treatment safely. At the beginning of the pandemic, there was a lot of uncertainty, but I think pretty much everyone, although this is not universal, pretty much everyone in London agreed that we should continue treating patients on treatment where appropriate, and new patients who needed treatment should get it. And indeed, that's what happened. One of the really challenging issues that we faced during this time was there was no guidelines about which treatments were safe. And also it wasn't clear about if you gave things like chemotherapy, about whether that would predispose to increased mortality. Actually, the retrospective data now coming out suggests that most of the treatments we give are safe, but the key issue is that age is a key risk factor, and having growing cancer is a key risk factor. Chemotherapy, immune therapy, less of a risk factor as such. What we did was the first thing that we were lucky in that we have a site which doesn't have an emergency department on it, which allowed us to put barriers to getting into the cancer centre, checks. So we get patients, we've had a triple check process. So patients would be phoned to make sure they didn't have symptoms. They would then be checked on the door, and then a check to get into the chemotherapy area. We obviously stopped visitors. Carers were allowed to come with patients. During this period of time, we actually gave 9,000 treatments to cancer patients. We treated over 3,200 cancer patients. We put in routine testing of cancer patients. So we would be testing cohorts on a weekly basis to look at the underlying prevalence of COVID to see how successful our screening process was. And actually, during the first few weeks, when testing was, I think, pretty uncertain, we didn't collect great data. But actually, since almost the 1st of April, we've been getting regular data, and you can see almost from the 1st of May, we've had no positive tests, 1 or 2 perhaps. And when you look at the percentage positivity, it's less than 0.2%. And we could show no increased mortality associated with having systemic therapy. So in summary, we went through a process of uncertainty. We made decisions that we had to keep going with cancer treatments, as the vast majority of cancer centres, but not all, agreed. We continue to treat patients, and we continue now, and it looks like that process has been safe.
That's very reassuring, Tom. Was there much, you obviously have a lot of colleagues all over the world. Is there an international consensus around the approach you've taken at Barts, or are different countries moving in different directions? So
we've been speaking to the National Cancer Institute in the Netherlands, to Institut Gustave Roussy in Paris, and Harvard in Boston. And those are the 3 centres that I've been discussing. And, you know, one of the things that, and of course, we've been talking to University College Hospital, the Royal Free, and Guy's and St Thomas's in London. There are 2 or 3 things we've noted. Number one is that it's very hard to give advice from a central perspective, and pretty much everyone's agreed with that, because by the time it's been written and approved, it tends to be out of date, number one. Number 2 is we've also noticed from a cancer perspective in the UK, and this is really important, if you speak to colleagues in Devon and Cornwall, in Wales and in Scotland, because the pandemic was moving at different speeds, putting UK guidelines in place, closing down Cornwall Cancer Centre to new patients was not a great idea. Because the consequence, that wasn't closed down, by the way, but I'm giving that as an example, because actually when you looked at their numbers, they were very low and it was safe. And perhaps it would have been safer to actually keep those going at full speed, of course, putting safety measures in place, and perhaps diverting patients who need urgent treatment under those circumstances. So the first thing we've learned from that is that actually local measures are crucial. The second point is when you look at the international response, it does seem that depending on how hard your area was hit is how cautious you've been as an institution. So for example, Amsterdam wasn't hit nearly as hard as Paris and London. And they have continued pretty much as normal because they haven't seen some of the more difficult scenes we've seen in London, Paris, and indeed New York. And Boston, Dana-Farber, I mean, they've continued. I would say, in my opinion, that Dana-Farber and Paris probably have turned around slightly more quickly. They've probably got testing and PPE slightly more quickly. And in fact, they're seeing many more face-to-face consultations than we are in London and in the UK. Overall, I would say when you look from an international perspective at these big cancer centres, they've tended to make the same decisions at the same critical point. But there's no doubt that testing cancer patients is very important, and PPE and protecting staff is very important. The one thing we fear most is a pandemic breakout on a chemotherapy day unit, where patients are giving it to each other, coming back 3 weeks later, and then giving it to the next group of patients. And that's what we're trying very hard to avoid, and that's internationally agreed. Thanks,
Tom. That's a very comprehensive response, and really great to get that international flavour about how the UK's approach compares and contrasts with others. So, Ewan, very briefly, you really led the cardiology as opposed to the cardiac surgery response to COVID. Can you just, in a minute or so, just say about how heart attack centres, the specialised cardiac units that are used to treat people with heart attacks very quickly, how they coped and how they changed during the pandemic months?
Yeah, sure, Charles. And keeping with much of what's already been said by others, a lot of the early planning was anticipating the potential for a surge in COVID cases. So all elective work was stopped, with consequent lengthening of waiting lists. Quite a number of the workforce in cardiac services were redeployed to support intensive care, and there was some bed redeployment, all for entirely appropriate reasons. But this meant that we had to plan for the potential for heart attack centres not to be able to cope either because of loss of staff or staff being off sick. So one of the things we did was to link heart attack centres so that they worked together and could offer mutual support. We also worked very closely with London Ambulance Service and changed the triage of some lower risk patients so that they went to district hospitals rather than to the major centres. And the very last thing to say, Charles, which you know very well, and others will be familiar with this, in sort of March to May, we saw something like a 40% reduction in presentations with ST elevation, myocardial infarction, and the need for primary PCI. And sadly, along with that, London Ambulance Service witnessed about the same percentage increase in out-of-hospital cardiac arrest. This is something that was noted around the world. And of course, the presumption is that actually patients were failing to call for help. So in the end, none of the major cardiac centres was overwhelmed. And in fact, changes to care pathways have now been restored back to pre-COVID arrangements.
Thank you, Ewan. I mean, it really was between a rock and a hard place. You know, that decades of advice about call for help early had to be said, well, you know, try to avoid going to hospital if possible. And I don't think one can blame patients in any way for not wanting to come in, but that particularly with heart patients can have very tragic results, as you've said. So I'd like to shift us now. We're now at a point, thankfully, in London where the incidence of COVID is very low. And for all the reasons that we've just discussed, our big priority is about getting back to normal treatment. So, Ewan, just again, briefly, can you give us an idea of how much of a backlog, if you like, has built up during these months where we weren't able to operate as usual?
Yes, sure, Charles. I'll leave Steve to comment on cardiac surgery, but for cardiology, waiting lists have extended very considerably, and we've had a process by which we've made an assessment of the urgency of various different patients on the waiting list. Capacity is heavily influenced by, of course, infection prevention and control arrangements, both for patients and for institutions, and that actually limits one's ability to get back to pre-COVID capacity. We have three main, essentially, pathways of care for cardiology patients. One is outpatients, another is their investigations, and the third is hospital care. For hospital procedures, we're probably back to around 70% of pre-COVID activity in the major hospitals, But in smaller hospitals, perhaps with only one catheter laboratory, they are at reduced capacity. For investigations, the big challenge, which most will know, is to do with delivery of echocardiography. We have something like 12,000 patients waiting for echocardiograms, and the challenge there is the shortage of cardiac physiologists, which existed even pre-COVID. We've made use of the independent sector. There's a lot of talk about developing diagnostic hubs. And with regards, finally, outpatients, about 90% of cardiac outpatients consultations have been virtual over the recent months. We do feel that that's too high a percentage because there is a need for physical examination of quite a number of patients, at least for first presentation. And so I would hope to see that we will move back to some more face-to-face contact, but we'll never return to the previous arrangements for outpatients.
Thank you. And that gives us a sense of the work ahead. And can I turn to Steve? Can you really answer the same question? You know, what's the size of the backlog in cardiac surgery, and where are you and where is London in terms of percentage of normal activity at the moment?
So, Charles, we've emerged to the start of the elective restart programme with 1,500 patients on waiting lists currently across London. As Ewan sort of referenced, what we have, however, is an unquantifiable sort of lost amount of activity which may return because of the loss of cardiological activity during the peak of the pandemic and afterwards. So it remains to be seen just how much impact that will have. Currently, we're operating at about 80% of business as usual capacity compared to pre-COVID across London at the moment, and returning to pre-COVID levels is variable across the 7 centres, but actually slightly more optimistic now than it was a few weeks ago. And I think we'll get back pretty much to 100% capacity within the next 2 months. It will still leave us with a very significant challenge because of that very large waiting list. And the different approach now, which is completely new, in fact, because cardiac surgery historically has never really been delivered on a pan-London basis or looked at it things through a pan-London lens, but that is now the agreement amongst the 7 centres, which is very refreshing and reassuring. And so we are determined that we will offer equity of access to patients, irrespective of how quickly or otherwise different units recover. The other thing I think it's important to say is productivity is about 20% less than it is pre-COVID because of all the things we have to do to deal with COVID around PPE, testing, pathways. We're looking on average at about a 20% reduction in productivity. So theoretically, to get back to our pre-COVID levels of delivery, we'd need 120% of pre-COVID capacity. So that's another factor in the mix. The two final things I just flag up is, despite the fact that patients are waiting for prognostic and potentially life-saving cardiac surgery, we still have a 1 in 5 refusal rate because patients are terrified of catching COVID. That is certainly improving as the general infectivity diminishes. And then the IPC protocols are a challenge. We've certainly relaxed ours, but we can't relax them too far because we know the consequences of patients catching COVID post-cardiac surgery. But the 14-day isolation currently, that is the requisite for major surgery, is a real challenge for our patients and the households who have to self-isolate.
Steve, we've just had a question through about your use of the independent sector. Could you just say a few words about that?
So we use the independent sector during the pandemic sparingly, and the problem there is that, of course, you have to staff the independent sector. They're going to provide the scrub nurses and perfusion, say, but in terms of the post-op care, that is a challenge. So although we used it, we didn't use it an awful lot. Moving forward, again, the challenge would be that in order to make safe staffing regimes, you would have to virtually transpose a unit from wherever it was into the independent sector. I think the independent sector will play a very important role in terms of offering us step-down options, both in terms of ward patients and intensive care. So there's certainly a role for the independent sector. And outside of cardiac surgery, it has to be acknowledged, the independent sector has done a really great job in supporting us through the pandemic with cancer surgery and now in the elective restart.
Great, thanks. So Tom, really the same sort of question about restoration of services, but just before that, we've had a question come through about radiotherapy services during the pandemic. Were they maintained, and how did you manage?
We were nervous about radiotherapy initially because clearly patients need to go through the same machine, and the challenges around chemotherapy and radiotherapy machines were the same. The difficulty is you can't really interrupt radiotherapy regimes. It's really frowned upon in a big way. And so to some extent, we had to keep going, test patients, and we randomly tested patients, and we tested patients with symptoms before they came in. We kept going with radiotherapy, and in fact, we never really stopped the delivery of radiotherapy. We modified some of the regimes, so there were without going into detail, you tend to give about 20 boosts, 20 shots of radiotherapy, they're fractions on one particular go. And in some regimes, there have been trials which have given 5 rather than 20. And the results might not be quite as good or pretty similar. And so we tended to modify or reduce our regimes where possible. But essentially with radiotherapy, we've kept going. And, the radiotherapy team, I think, has done a terrific job in that respect. Coming back to your question that you've asked is in terms of what's happening from a cancer perspective, I think the diagnostics were really disrupted, and we could see the referral patterns and numbers were reducing. As I said previously, that didn't have a huge alteration on the amount of systemic therapy we were giving, but certainly had a big effect on new diagnosis and surgery and upfront treatments. And there will inevitably be a backlog there. There's an unknown unknown. I hate to quote Donald Rumsfeld. I try to avoid American politicians if possible, but the unknown unknown really is around cancer. How many of those patients have gone on and progressed? How many, heaven forbid, have died and have missed the boat? And how many actually will be picked up over the next few weeks? Our big fear, and I'm sure you've seen this, there were 5,000 new cases in Spain yesterday. Our big fear is that this virus is not like flu, but actually will come back quite quickly. And coming back to Steve's point, cancer patients are now a lot less nervous than they were before because they took the advice from the governments literally, which was stay indoors. But now they're saying, well, I must go out and see my grandchildren and other people. And it's going to be much harder in a second peak, in my opinion, which I suspect is coming if we believe the Spanish data. It's going to be much harder to keep people safe and indoors, keep them isolated, and keep them COVID-free, which in turn will mean it's going to be much more challenging to keep that chemotherapy day unit and the radiotherapy day unit COVID-free. And then the last point, heaven forbid, if those numbers did peak, as I suspect they will, and those unknown unknowns will mean actually we're going to get doubling in our cancer numbers. Under those circumstances, we may struggle. We've got plans to cope under those circumstances, but I think we're a long way from being out of the woods from a cancer perspective.
Yeah, thanks. Thanks very much, Tom. That's a very sobering perspective, and leads on nicely to Jules. What are the plans in terms of intensive care? I mean, we certainly, as a system, as a country, and as a city, we were slightly caught on the hop in that we've operated with low levels of intensive care beds relative to other countries for a long time, and we've put up with that. What are we doing to fix that more permanently?
Yes, thanks, Charles. So our baseline critical care beds in the UK are probably in the lower quartile of our comparators in Europe and North America. In London, we probably have about 780 to 850 beds, depending on how they're counted. And at peak epidemic, we had 1,000 COVID patients and just over 200 non-COVID patients in ICU beds. I think before I go on immediately to talk about what we're doing, it's really important to give appropriate credit for those people who were redeployed to work in crit care. Both the clinical leaders across the multiple specialities and their colleagues were incredible in terms of their enthusiasm and drive. What we're now doing with very few patients now in crit care is planning for winter, and a hard winter. We're setting up where we're going to put surge capacity early. So we've got plans for opening beds that we can open within 48 hours, within 7 days, and within 28 days. And we know that we can achieve approximately 1,600 beds, by example, for London over that period. without impeding theatre capacity or recovery capacity, because our aspiration this time must be to try and maintain that some more elective workflow. In doing that, our main point of potential weakness is workforce. Our great strength is our great weakness, and really indebted to all of the trusts who are undertaking training programs for their multi-professional and multi-speciality teams, and particularly the education program that came out of the Nightingale experience, which is now being rolled out across London. And that is really facilitating that multi-professional learning and opportunity. We need to maintain those transfer teams that we did previously so that we can stabilise centres and maintain things. And we're also on a separate stream of work looking to increase our permanent critical care bed stock so that we don't in the future cancel surgery ever because of lack of a critical care bed, or delay admissions, or delay into hospital transfers.
Yeah, thanks, Jules. So I'm going to start to wrap up, really. I think what we've heard is, despite this immense challenge that these areas of specialist care, intensive care, cancer treatment, cardiology and cardiac surgery really did rise to the challenge, and we have managed to sustain at least emergency services very well in London during the pandemic. The key bit that I think I've heard from all of you is how one of the silver linings to this terrible disease has been increased collaboration between centres, and how London as a city has begun to work together as opposed to the old days where it was very much one hospital doing its thing and maybe not collaborating so much. So if there's any positivity to take away, I think that's it. I think that has been a really something that we need to celebrate, but also ensure continues. So I'd like to thank all our experts today. It's been great. It's been wonderful hearing from you, and thank you for all you did for Londoners over the last few months. So just to finish, I should let you know that the next one of these webinars is next Thursday, the 13th of August at the same time. And that very appropriate subject is managing local outbreaks. And that features Ivan Brown, who's the Director of Public Health for Leicester City Council, where they've obviously just been through a local lockdown. So that will, I'm sure, be incredibly interesting. And thank you all for listening, and thank you all for your contributions.